Good morning. I am Dr. Saurabh Piparsania. Today I will be talking on sickle cell anemia. The learning objectives of today's lecture would be: what is sickle cell anemia? What is its pathophysiology? What are the common clinical features of sickle cell anemia? What are the different types of crises seen in patients with sickle cell anemia? What are the laboratory studies done, and how do you manage a child with sickle cell anemia? Sickle cell anemia is a group of inherited disorders with abnormalities caused by HbS, that is hemoglobin S. It is an autosomal recessive disorder resulting from a single base pair change, that is thymine for adenine at 6th codon of the beta globin gene. This change encodes valine instead of glutamine, and sickle cell anemia occurs when both the beta globin gene has sickle cell mutation. As I have already spoken, that it is an autosomal recessive trait. So this slide shows the pattern of inheritance of disease. If both the parents have sickle cell trait, that is HbAs, there is 1 in 4 chances that any given child could be born with sickle cell anemia. There is also a 1 in 4 chance that any given child could be completely unaffected, and there is a 1 in 2, that is 50% chance that any given child will get the sickle cell trait. Now, if one parent has sickle cell trait, that is HbAs, and the other has sickle cell anemia, that is HbSS, then there is 1 in 2, that is 50% chance that any given child will get sickle cell trait, and 1 in 2 chance that any given child will get sickle cell anemia. No children will be born completely unaffected. Now, if one parent has sickle cell anemia, that is HbSS, and the other is completely unaffected, that is the other patient, partner is completely normal, then all the children will have sickle cell disease, sickle cell trait. None will have sickle cell anemia. The parent who has sickle cell anemia can only pass the sickle hemoglobin gene to each of their children. Now, if one parent has sickle cell trait, that is HbAs, and the other does not carry the sickle hemoglobin at all, that is the normal hemoglobin, then none of the child will have sickle cell anemia. There is 1 in 2, that is 50% chance that any given child will get one copy of the HbAs gene and therefore have the sickle cell trait. It is equally likely that any given child will get 2 HbAa genes and will be completely unaffected. So, to conclude that a baby will born with sickle cell disease if 2 sickle cell genes are inherited, one from the father and one from the mother. A person who has 1 sickle cell gene is healthy and is said to be a carrier of the disease. Now, who are at risk of developing sickle cell disease? The disease originated in at least 4 places in Africa, Mediterranean countries such as Turkey, Greece, and Italy, and in the Indian and Saudi Arabian subcontinent. It exists in all countries of Africa and in areas where Africans have migrated. In India, MP, that is Madhya Pradesh, Maharashtra, Orissa, and Jharkhand have sickle cell belt. Now, why the patient with sickle cell anemia have different clinical manifestations? What is the difference between the normal RBCs and the sickle RBCs? Normal RBCs appears like a smooth letter O, which is round and flexible, and it moves very easily in the body, and the lifespan is 120 days. In comparison to this, sickle RBCs are stiff and sticky, formed into the shape of sickle or letter C. They tend to cluster and cause a blockage and stops the movement of normal RBCs. And the average lifespan of sickle RBCs is 15 days with a range of 10 to 20 days. This is the slide showing the structure of normal and sickle RBCs. Figure A shows normal red blood cells flowing freely in a blood vessel. The insert image shows a cross section of normal RBCs with normal hemoglobin. In figure B, abnormal sickle RBCs are seen clumped and blocking the blood flow in a blood vessel. The insert image shows a cross section of a sickle RBC with normal strands of hemoglobin. Now, what is the pathophysiology? The amino acid substitution results in hydrophobic amino acid being substituted by hydrophilic amino acids. Deoxygenation of HbS results in the polymerization of HbS molecule. The polymerization of HbS results in the distortion of RBC and decrease in the deformability. These results sickle cell obstruct the microcirculation, leading to hypoxia and vaso-occlusive crisis. Now, what are the factors that affect sickling? There are certain factors that promote sickling and there are certain factors that decrease sickling. Oxygen. Oxygen is a very important stimulus that decreases sickling. Okay, so in a deoxygenated state, whenever there is deprivation of oxygen, the chances of sickling are more, and when the oxygen is in adequate amount, the chances of sickling will be less. As hemoglobin concentration, high concentration of HbS increases the chances of sickling, and high level of fetal hemoglobin decreases sickling. HbS concentration, that is hemoglobin concentration, that is high MCSC increases the chances of sickling, while low MCSC decreases the chances of sickling. Dehydration increases sickling, while normal hydration and overhydration decreases the chances of sickling. That is why a child who are sickle cell positive are given good hydration therapy and oxygen support, which minimizes sickling. Temperature, fever increases the chances of sickling. Acidosis again increases sickling, as in opposed to acidosis, alkalosis decreases sickling. High level of 2,3-DPG again increases sickling, and low level of 2,3-DPG decreases sickling. So these factors are taken into consideration whenever we manage a child with sickle cell anemia. What are the signs and symptoms? Signs and symptoms in an individual vary. Some patients will have mild symptoms, others may have very severe symptoms and may be hospitalized for their treatment. Present at birth, many infants does not show any signs until after 4 months of age, because the predominant hemoglobin in this age group is fetal hemoglobin. We can see the usual signs of anemia like fatigue, tooth failure, pale skin and nail beds, jaundice and shortness of breath. Pain is the most important and the characteristic sign of sickle cell crisis. Sudden episode of pain throughout the body may occur, and the common sites where pain is complained of are bones, lungs, abdomen, and joints. Lack of blood flow can cause pain and organ damage. Various types of crises are seen in patients with sickle cell anemia. These are vaso-occlusive crisis, acute chest syndrome, sequestration crisis, aplastic crisis, and infection. Now we will discuss all these crises one by one. Vaso-occlusive crisis, sorry. Vaso-occlusive crisis is because of the obstruction of the microcirculation by the sickle cell, which leads to ischemic injury. Pain is the chief complaint, and bones which are commonly involved are femur, tibia, and lower vertebrae. Vaso-occlusion may present as dactylitis or as hand and foot syndrome, that is painful swollen hands and or feet in children. Vaso-occlusive crisis may sometimes mimic acute abdomen. Retinal hemorrhage may occur. The skin develops autoinfarcts and may become fibrotic. In the kidney, it results in papillary necrosis, which results in isocynuria or inability to concentrate urine. Priapism may occur, and avascular necrosis of femoral head can also occur because of this vaso-occlusive crisis. Second important crisis is acute chest syndrome. It is a type of vaso-occlusive crisis in which the child develops tachypnea, that is the fast breathing, dyspnea, chest pain, and fever. On doing X-ray, the presence of new pulmonary infiltrate is suggestive of acute chest syndrome in a child with sickle cell anemia. Sequestration crisis. It is due to the sickle cells blocking the flow of blood in the splenic circulation, leading to the pooling of peripheral blood in the engorged spleen. One of the most important clinical features is sudden onset of paleness in the baby or the child, and enlargement of the spleen. This is a characteristic of the sequestration crisis. Aplastic crisis. It is because of the failure of the bone marrow to produce RBCs. Most commonly, it is caused by parvovirus B19, and sometimes it may be associated with folate deficiency. Children with sickle cell anemia are more prone to develop infection by encapsulated organisms like Streptococcus pneumoniae, Hib. Other organisms that can cause infection in sickle cell anemia are Salmonella typhi, Mycoplasma pneumoniae, Staphylococcus aureus, and E. coli. Laboratory studies that are done include CBC, which will show anemia, thrombocytosis, and leukocytosis may or may not present. Reticulocyte counts are often increased. Peripheral smear for anemia typing will show microcytosis, hypochromia, sickle cells, and target cells. Howell jolly bodies are seen in patients who have undergone autosplenectomy. Serum bilirubin levels may be raised in patients with sickle cell anemia, and the type of hyperbilirubinemia is usually indirect. On doing sickling test, it is positive, and diagnosis is confirmed by hemoglobin electrophoresis. Other investigation that can be done in a child with sickle cell anemia are urine RM, ultrasonography of whole abdomen, blood culture sensitivity to rule out sepsis or infection, X-ray chest to rule out acute chest syndrome, CT and MRI because of sluggishness of the blood flow or the vaso-occlusive crisis. Infarcts may occur in the brain, which may help in which may be diagnosed by CT scan or MRI and ECG. Management. Many children with sickle cell anemia do not require hospitalization and can be managed at home, while few patients with sickle cell anemia having severe symptoms often require hospitalization. The mainstay of therapy are maintenance of hydration, as we have already discussed that good hydration reduces the chances of sickling. So maintaining hydration is of prime importance after hospitalization of the child. The fluid used is normal saline or with dextrose. Second, oxygenation, because deoxygenation stimulates sickling, so oxygenation will reduces the chances of sickling. So second most important therapy is adequate oxygenation in the child. As pain is one of the most prominent symptoms in children with sickle cell anemia, pain control measures should be taken. For this, drugs are used, which include acetaminophen, NSAIDs, codeine, and narcotics such as morphine. IV antibiotics are required only if infection is suspected. Blood transfusion is indicated in patients with severe anemia or who present with acute sequestration crisis in which there is sudden fall in the hemoglobin level and enlargement of the spleen. And second is aplastic crisis when the bone marrow fails to produce RBCs. These are the conditions in which blood transfusion is indicated. And we prefer to transfuse PET cell volume or red cell concentrate, which are leukodepleted or washed RBCs. Exchange transfusion is indicated in children with cerebrovascular accident and in children with acute chest syndrome Hydroxyurea and folic acid has been tried with limited success in children with sickle cell anemia. How can we prevent sickle cell anemia? Prophylaxis with penicillin and amoxicillin is given till 5 years of age in all children with sickle cell anemia. Consider immunization against encapsulated organisms like pneumococcal, meningococcal, and Hib vaccines. These are to be given in all children with sickle cell anemia. Hydroxyurea is started after 5 years of age. It reduces the chances of, it reduces or minimizes the requirement of blood transfusion, painful episodes in the children, and incidence of the acute chest syndrome. Parental counseling is a very important aspect in managing a child with sickle cell anemia because it is an autosomal recessive disease. So a proper counseling of the parents must be done, and they should be taught about the condition of the condition with which the child is suffering. Genetic counseling is again very important in determining whether how the next pregnancy should go. Thank you.